స్టార్ట్ చేసేమన్నారు కావ్య. ఉమ్, ఆ, సరే సార్. ఓకే సార్. ఓకే సార్. బాయ్.
ఎలక్ట్రాన్ గెలిచిన పని ఉంది చూపించుకొని
అవునా, విజయ్ అక్కడ ఉన్నారా? పోస్ట్ ఆన్ చేయాలి. కావ్య సురములు మీరేనా? కావ్య గారు, కావ్య గారు, డాక్టర్ కావ్య మీరేనా? పర్సన్ హలో. అభిషేక్, ఓకే సార్, థ్యాంక్ యూ. ఒకసారి జాయిన్ అయిపోతే నేను హోస్ట్ చేస్తాను. హోస్ట్ చేస్తాను కాదు కదా.
పేరు కానీ ఉంటుంది.
మేడం, మేడం, is it free time? Can you provide your... Hello? Yes, madam. Yes, madam. I need ultra viewer access, madam. Yeah. If you open ultra viewer, it will ask ID and password.
Dr. Ajit sir, afternoon. And afternoon to all the AMT's team. Hello.
Hello.
Afternoon to all the AMT's team. This is Dr. Rajkumar.
Yes, good afternoon, Rajkumar. We'll just start the meeting in 5 more minutes. Let other participants also join the meeting.
Sure. My wishes to Dr. Ajit Singh also. So I visited AMTZ last year, I think, or before last year, I visited AMTZ and Kalam Institute of Technology. So we have interaction with Mr. Naresh
Okay, sir.
and other members there who are
Sir.
projects or biomedical projects. Also, I interacted with them. At the time, I came from Gitim University at the time.
Okay, great, sir.
So it is it is my nice experience to interact all of you, and it is a very well-fledged and well-structured organization. This is my brief introduction. Okay, then thanks to all.
Yeah, thank you, sir.
Yeah. Madam, before I have one query. Are you providing participant certificate?
Yes, sir. By tomorrow, once we get the registered participation list, and we'll just tally with the people who have joined this, we'll be
Okay.
providing.
Okay, then, because we didn't receive any form like that. That's why I'm asking.
Yeah, sure. We'll be sharing you the feedback form at the end.
Okay.
So based on that, we'll be sending you the certificates.
Sure, madam. Thank you. I'm putting in mute to avoid disturbances then, right? Thank you.
Sure.
Yeah.
Good evening, everyone. We'll just wait for a couple of more minutes. I think we have a few more people who will be joining us, and then we'll start with today's session.
हाँ સાથે બધી ચીજ તો કરી પેલો આંખમાં આવ્યો નહીં એને રિપોર્ટ લેટર મોકલાઈ દીધું
Good evening, everyone. A very warm welcome to all of you for joining us today. I am Aryaman, a senior fellow in Kalam Institute of Health Technology, and I'm delighted to open today's webinar hosted by the Kalam Institute of Health Technology in collaboration with ISPOR India Karnataka chapter, led by Dr. Anant Nayak Nagappa. A brief overview about Kalam Institute of Health Technology. Kalam Institute of Health Technology, which is also a World Health Organization collaborating Center for Health Innovation, aims to facilitate focused research on critical components pertaining to medical devices by supporting institutions involved in R&D, industry, policymakers, and knowledge repositories. This is achieved through transfer of technical knowledge and bridging strategic and coherent strategy of scientific facilities and institutions to complement efforts on industrial promotion in the medical device segment. It lives to bring increased access to affordable health products to citizens and a thriving medical device manufacturing sector in India. At Kalam Institute of Health Technology, we constantly work to build stronger capacities in evidence based research, health technology assessment, and policy relevant analytics. Today's session is a step in that direction. We have with us today the Chief Operating Officer of Kalam Institute of Health Technology, Dr. Kavita Kachru, who will give a brief overview of the departments under Kalam Institute of Health Technology so that you have a better understanding of what we do. So over to you, Dr. Kavita.
Hello, everyone. Can you see my screen?
Yes, ma'am.
Okay. And I am audible as well?
Yes, ma'am, you're audible.
Okay. So greetings. Thank you, Ariman, for that introduction. I am Dr. Kavita Kachru, Chief Operating Officer, Kalam Institute of Health Technology, which is also a WHO Collaborating Center for Health Innovations. As you can see, Kalam Institute of Health Technology has been set up in the name and honor of our beloved President, Dr. APJ Abdul Kalam, and is one of its kind globally.
When you are talking.
It is a Government of India project supported by Department of Biotechnology and is also a WHO Collaborating Center for Health Innovation. It also draws its credibility from the fact that Kalam Institute is housed itself at AMTZ, which is Andhra Pradesh MedTech Zone, which is based at Vizag and is the world's largest medical device research, development, and manufacturing cluster. As Dr. Kalam once said, innovation distinguishes between a leader and a follower. With this in mind, KIST is leading the charge to transform healthcare innovation globally. Just let me give you a perspective and an overview of what Kalam Institute is and about our verticals, departments, and global collaborations. So, coming to departments, we have Center for Market Intelligence and Trade. We have Clinical Research Organization first. We have second as Price Monitoring Resource Unit. Third as Kalam Blood Center. Fourth, International Journal of Health Technology and Innovation. Fifth, In Vitro Diagnostic and Testing Center. Kalam Certification Services, Center for Health Technology Assessment, and Center for Market Intelligence and Trade. Coming to our global collaborations, we are a JVI affiliated group. We are also a partner to University of Washington's START Center, which is Strategic Analysis Research and Training Center. We are also partner with Health Technology Assessment International. As I already mentioned, that we are a WHO Collaborating Center for Health Innovation, and we do a lot of work with WHO headquarters at Geneva, mostly with Innovation Department. We are also a partner to International Agency for Prevention of Blindness, as we have a dedicated assistive technology unit under AMTZ. In that capacity, we have an access and partnership with International Agency for the Prevention of Blindness. We are also partner to HEOR, the Professional Society for Economics and Outcome Research. And as mentioned by my colleague, Mr. Ariman, this webinar series we are doing in partnership with HEOR. Let me show you some of the initiatives which we have done under this collaboration. Kalam Institute of Health Technology is leading all the Indian eSport chapters. We have tried this year to bring everyone together at the same platform and to ignite and to initiate the capacity building around health economics and outcome research with the help of this webinar series, which we are hosting every month. And we also would be updating India's pharmacoeconomics guidelines for health technology assessment and health economics and outcomes research for India. We also would be doing some research activities and publishing white papers on health economics and outcomes research. And we also are hosting World Health Innovation Forum in the month of December from 11th to 13th December. If anybody is interested in participating, do let us know. And if you are also struggling with any research activities, you want to do an HTA, you want to work in this area, you can reach out to us and we will definitely try to help you and accommodate you. As you can see, and I was mentioning the list of webinars which are already conducted and which we would be hosting. We also host health technology assessment fellowships. So this next year in the year 2026, from 10th to 15th March, we would be hosting 11th International Fellowship on Health Technology Assessment. And with this fellowship, we try to bring world-renowned experts in this field. So we have Dr. Anirban Basu from the University of Washington. We have Dr. Prakesha from the University of Toronto. Like we also have Dr. Anuj Mobai. He is from University of Arizona. We have other renowned expert, national, international, who would be teaching on health economics and outcomes research, health technology assessment. If you are interested, you can also get in touch with us to join this fellowship program as well. We also generate this GlobeXam. It is like global export and import analysis on medical devices. This report is available on our website. If you are working in the space of global medtech devices, this booklet will give you a bird's eye view of what is happening in India and globally in the space of medical technology. What is the trade deficit? When India would be import neutral, we capture all those insights in this book. If you're interested, you can reach out to us to buy a copy of this booklet. This booklet will also give you an insight if you have to do a research. Where is the gap? This book has listed all the gaps on the areas or on the devices where we are highly importing at this point of time. If you want to have a glimpse of this book, you can reach out to us again. Then, as I already mentioned, that we have an in-house journal known as the International Journal of Health Technology and Innovation. If you have any papers, publications, you can reach out to us and you can be in touch with us. If you need any assistance as well in writing, we can help you out, and we can also help your publication or paper to publish in this journal. Last but not the least, as I mentioned again, we would be hosting Third World Health Innovation Forum from 11th to 13th December. If you have any research abstracts which you want us to publish, you can submit those to us and you can get an opportunity to present during World Health Innovation Forum. In this forum, you have delegates from all around the globe, and it's like policy makers, delegates from across the globe will be here at Vizag in our zone. You all are welcome to participate in Third World Health Innovation Forum from 11th to 13th December 2025. With this, I close my talk and over to you, Ariman. And back to our speaker. I welcome you all for today's webinar. Thank you. Thank you so much.
Thank you so much, ma'am, for that overview about Kalam Institute of Health Technology. The topic for our webinar today is both timely and essential, which is the role of HEOR in shaping public health policy from local to global impact. Health economics and outcome research has increasingly become a cornerstone in guiding evidence-based policy decisions, whether it's assessing the cost effectiveness of vaccines during the COVID-19 pandemic or evaluating the value of innovative cancer therapies for national reimbursement programs, or informing the allocation of limited healthcare resource in low and middle income countries. At the global level, HEOR insights are being used by organizations like WHO and national health agencies, and helping them strike a balance between affordability, accessibility, and innovation. So, at the local level, they are shaping the state health insurance schemes, improving procurement practices, and ensuring that patients get the maximum benefit from the every rupee or dollar that they spend. With this context in mind, it's my pleasure to now introduce our distinguished speaker, Dr. Ajit Singh, who is the founder and CEO of Climate and Curio, who will take us deeper into how HEOR drives these critical decisions. Dr. Ajit Singh is a young entrepreneur scientist with a PhD in cardiology from Manipal Academy of Higher Education. He has served as a research scientist at ICMR, National Director for Research at World Youth Heart Foundation, and Vice President of the Medical AI Wing at Indica AI. With over 50 publications across cardiology and related fields, Dr. Singh has been an investigator in several international clinical trials and a reviewer of leading journals including Oxford, BMJ, and Springer Groups. Recognized with the Young Achievers Award in 2019 and Young Scientist Award in 2020, he has presented his work in more than 15 countries, most recently completing a super specialization in cardiology research uh, under the European Society of Cardiology in Italy. Before we begin, a quick note for all the participants. Please keep your microphones on mute during the session. If you have any questions, feel free to drop them in the chat box. We will take them up during the question and answer session at the end. Now I invite Dr. Rajit to take us through today's session. Over to you, sir.
Thank you very much, Aryaman, for the wonderful introduction. And I would like to, extend my thank to Kalam Institute of Health Technology for inviting me and giving me this opportunity, and Dr. Kavita Kachru. Thank you very much, and everyone who is listening to me here. So right now I'm at my home. I had to come yesterday for some medical emergency, but yes, as I promised, I'll be taking your session from my home. Okay. So let me share my screen, guys. Okay, I'll be expecting all of you to be on mute if you're not speaking, and you can, unmute and speak anytime in between if you are having any queries. Okay. So is it visible fully?
Yes, it's visible, sir. Yeah,
Okay, full screen, right?
full screen.
Okay, so thank you very much, guys. I'm Dr. Ajit. So let's talk in a brief about the role of HEOR in shaping the public health policies from local to global impact. So, what is HEOR? What are the components of HEOR? And what's the process of HEOR? And then we'll be, taking some wonderful examples of, public health policies in India, which we, take up locally, and then we'll be talking about some, global examples and global initiatives of HEOR, where HEOR is being used and how they are, using the health economics and outcome research for the, public policy making, right? And then I have kept 4 or 5 slides on call to action, right, where we will be discussing how to do, what to do, and what is needed right now to do in the future if you want to practice HEOR, if you want to, improve HEOR. So as okay. Yeah, so there is no conflict of interest. I do not have any conflict of interest. This PPTs are created from the multiple resources. So first, let's talk about what is HEOR. So I'll start with this question to all of you: is this intervention not only clinically effective? If we are so this is an example. This is the this is the wonderful example when we we can describe the entire HEOR with that. So is this intervention not only clinically effective but also worth the cost to society? So let me give you an example. Suppose, just right now, just a year back or year and a half back, India has launched their indigenous vaccines for HPV, right? So that is for young women. They have to take the HPV virus vaccine, right? They have to take the vaccine for HPV, right? So they can, get rid of the cervical cancer, right? So because of, when because see, if you look at the HPV virus, if you look at the HPV infection, if you look at the infection, or if you look at the cancer, right, related to HPV, that is a risk, that is a health risk for each and every young girl, and not only young girl but the adult women, right? It is a risk for everyone, not only for one person. So in that case, we just don't need the vaccines for who developed the cancer, but we need the vaccine for everyone to prevent the cancer in initial stages, or before before the infection itself, right? So this is not just a medicine, this is not just a, the treatment, this is the prevention, this is the prophylaxis, and it should be given for everyone, or it should be taken by every woman, right, or every young girl in the age of 13 to 35 or 40, right? So it has to be given to everyone. So that that is, how it is possible. It is not possible by the, the everyone will not buy and, take this kind of vaccines. So what government do in these things, what the, whatever the state governments or the, national governments do in that case, they, assess the risk first. Okay, what's the risk of, cervical cancer? And they, they take care of, the policies. They prepare the policies, like how we can prepare, something where this vaccine can reach everyone at the lower cost, right? And they come up with the plans, they come up with the policies, they come up with, something where the cost of the vaccine is very less, or it is given, complimentary, or the companies are subsidized, to give the vaccine at a very lower cost to the, young women or to the population, right? So that's where we need the health economics, right? So it is like economics, the economics is nothing but, the mathematics and, use of some formulas where we, take care of the, costings, where we take care of the costings. And when it comes to the, healthcare sciences, when it comes to the vaccines, or when it comes to the drugs, or when it comes to the healthcare policies, where, so it becomes the health economics. So in health economics, we just not look at the cost like economics, we look at the benefits plus the cost. If it is costly, how much benefit it will be giving to the society, right? So that's how we measure the, risk, and we measure the cost, and then we measure the benefit of that intervention means it could be, it could be the vaccine, what I was talking about, HPV, right? It would be, anything else. It could be a drug, it could be a, drive for the low hemoglobins. It could be, the, what we say, the iron supplements. It could be the calcium supplements, right? So, or it could be anything which is in the favor or in the benefit of society, right? So that's how the government, state governments, public governments, or the central governments, or, the hospitals or the industries, right? So not only one thing, or the NGOs, they, prepare themselves by, finding out, by calculating the cost, and along with the cost, they, calculate the benefit, right? So the intervention, if it is really worth giving to the society at the cost whatever it is right now, or we have to cut down the cost, or, we have to raise the cost, or whatever cost, I mean, what kind of cost we can fix to the society or to the population with this benefits, right? So that's how we, integrate HEOR, we integrate the health economics, right? Calculating, and outcome research means what are the benefits. So benefits could be in the sense of, reducing the mortality of, as we were talking about the example of HPV. So, the mortality, the deaths related to the cancer, or, the morbidities, the other problems, consequences of the cancer, or maybe, the other problems, right? Health related quality of life of the people, right? So that all comes in the outcome, right? So HEOR is the combination, HEOR is the blend of economics, the mathematics, and the benefits, right? So this question, is this intervention not only clinical effective but also worth the cost to the society? So here we, calculate the cost in against the benefits to the society. So health economics and outcome research is a multidisciplinary field that evaluates the healthcare interventions by combining the clinical outcomes, what I was talking about, the mortality, morbidity, or the, patient outcomes, or, the their hospitalizations, or their, what we say, the healthcare related, quality of life, health related quality of lives, or health related, quality adjusted years. There are multiple things what I'm going to tell you in the next slides, right? And then definitely we talk about the cost, we talk about the patient reported experiences means how they experience after the, intervention, like their quality of life, okay, and how they're feeling now, how was the disease, and how they're feeling after the vaccine or after the intervention, right? So that all comes under the HEOR, okay. So why we need HEOR? HEOR definitely, is very important for the budgeting, because sometimes the healthcare budgets in the government, central government, or, in the state governments are very limited. They don't have much budgets, right? They have limited budgets, but our population, India is one of the largest population, right? India has one of the largest population in the world, but our health budgets are very limited, right? Our healthcare resources are very limited. So What we need is we need some good plans. And how to make these plans? These plans are made by HEOR. These plans are made by the HEOR process. These plans are made by the HEOR concepts, HEOR methods. Right. So HEOR helps the governments, policymakers, payers, and providers to allocate the resources where they can create the maximum health benefits per unit cost, right? As I was telling that, like how much they have to spend to per person, to everyone, to the entire population, right? So they calculate the cost, they calculate the benefits, calculated benefits, and then based on that only, they create the budgets. They create and they, utilize the given resources at their best. I think some people's mic is on. Some people's mic is on. Can you please turn off your mics, guys? It will be very, very good if you're turning off your mics, everyone. Okay. Thank you very much. Yeah. So they ensure the decisions are made based on the value, not just the affordability. Value means the benefits, health-related quality of life, or the benefits to the society. How much mortalities has come down, how much our society is, healthy, right? And HEOR also guides the drug pricing, reimbursement policies, and these supports the public health programs like vaccinations, chronic disease preventions like HIV, tuberculosis, and certain, the cancers, vaccinations, right? And also it helps building the evidence for the universal health coverage, which is a global initiative. I'll tell you about that, and the value based healthcare models like Markov models or multicentric models where I mean these are the methods how we utilize those methods to calculate the proper cost, calculate the very much requiring cost, or what we say the affordable cost at the maximum benefits, right? So, core components of HEOR, there are three major components. One is the economics. As I told, we need the mathematics to calculate the cost, right? And there are multiple methods like the cost effectiveness, cost utility, budget impact of the interventions. So we have to calculate the cost, and we have to find out the best outcomes based on the cost. And how we do that? We get into the real world evidences, we get into the electronic health records, we do the research, by registries, we do the research by observational studies, we do the research by multiple type of clinical trials, we do the systematic reviews, and then we check the databases from the government, we take the policies, and then we help to get the best outcomes at the lowest price, or the minimum price or minimum cost, right? By using the health economics, or by using the cost effectiveness and cost utility methods, right? So these are the three major components. One is health economics, right? To calculate we need, and outcome research, what we usually require after calculating the cost, like the maximum benefits and the best outcomes. And what we use to do that, we need real world evidence, RWE, right? So we take all the data from the RWEs, right? We take the demographics data, as you can see the picture, professional claims, quality measures, and social determinants of the health, right? Income, their locations, geographical locations where they live, their what are the occupations, right? Their educations. So all the determinants which can help them calculating the best cost and calculating the outcomes, right? Financial informations, pharmacy claims, institutional claims, all we check in the health economics and outcome research. So tools and methodologies, as I was telling, there are certain tools and methodologies. One, the first one, which is very important, is economical evaluation, right? How we calculate the cost, right? So there are multiple costs, as you can see. First is cost effectiveness analysis, right? So these are the tools and technologies, right? And the methodologies. You must have always you must have definitely read about it, but I'll just tell you in the brief, because you are from KHT, or you are from the other institutions you're joining. But I'll tell you in the brief. Like first is economic evaluation method. First in that is cost effectiveness analysis, CEA, right? So it compares the cost and outcomes, like cost per life year gained. If we are spending 1 lakh rupees, if we are spending 50,000 rupees, how much years of the life, how much years or how much days, how many days or how many months of the life we are extending after giving that, cost, after paying that cost to the healthcare, right? To the hospitals, to the medicines, to the resources, like to the ICU, or to the all the tests, all the blood tests, all the whatever resources we have used, or whatever injections we have taken, right? So how much we have spent on the healthcare, and how much we are earning means in the in the life year gained. That life year means it could be days, it could be months, it could be years, right? So that we calculate. So for an example, if I give you evaluating whether a new diabetes drug provides better survival at a justifiable extra cost compared to the existing drug. Suppose right now metformin is there. Suppose sulfonylureas are other drugs which have come to the market. DPP4, PDPP4 inhibitors are there. There are, there are other drugs. There is, very new drug, SGLT2 inhibitors, right? So SGLT2 inhibitors like, dapagliflozin and all, these are very, very, beneficial drugs. These are very ultimate drugs. These are very, if I say the first line of drugs right now for the diabetes. So because they improve the quality of life, they may not improve the survival, but they improve the quality of life. They improve the survival as well, right? So we count like how much cost we are paying, and how much benefits in terms of cost per life year we are getting. Then it comes to the second thing is cost utility analysis. Utility analysis, we use the quality adjusted life years. How many months, how many years are adjusted in terms of quality of life and in terms of quantity both, right? In the first cost effective analysis, we were just counting the quantity, like how much years or how many years or how many months we gained extra, right? But it is not only about the effectiveness, it is not only about the life year gained, but it is also about the quality of life. Nowadays, the HEOR, not only the HEOR, but all the guidelines, all the the research, and all the clinical trials, all the direct clinical trial outcomes, they're not only focusing on outcomes, they're focusing on quality of life, because quality of life is important. See, suppose one person is living for 5 years, right? But his or her quality of life is not good, right? They are always suffering, they're always in pain. I mean, after giving the drug, they lived for 5 extra years, but their quality of life is not good. They're always in sufferings, they're always in pain, right? But someone who is living for 3 years but pain free, right? So we have to calculate everything. Now we don't just focus on the length or the the duration what we gained extra, but we look at how the person is living, happy or not happy, right? So that is quality adjusted life years, right? So here we check the quality adjusted life years gained, and like suppose in the cancer therapies, or suppose in the vaccinations, or in the diabetic drugs, or the tuberculotic drugs, or anything. So these are some methods. There are some formulas what we usually. So I'll suggest you to go back and check the formulas as well, because if I talk about cost effective analysis or cost effective analysis, these are the entire topics. I'm just telling you in 2-3 lines, I'm just giving you the brief, but these are the big topics to learn. These are the big topics. If you're interested in HEOR, you must go and check out, right? And then cost benefit analysis, where we convert the outcomes into the monetary terms. Like suppose it usually done by the by the governments when they go for the vaccination drives. It's done by the companies when they create some new drug or create some new vaccines, and they definitely look at the benefits also, the monetary benefits also, right? Cost benefit manufacturing analysis means they look at the good outcomes as well, and based on that, how much monetary benefits they are taking, right? Or how they are getting, right? So converts outcome into the monetary terms to compare directly with the costs, right? Estimating, for example, estimating the economic return on mass vaccination program. Like suppose we are talking about the HPV vaccine only. So HPV vaccine costs around there are different vaccines, 1,000 to 2,000 rupees per shot, right? Or yeah. So the different companies check out like how much is our target, how much we will get, and what will be the benefit to the society, and not only the benefits, but how much we will earn in the back, maybe 200 or 300 or 400 after subsidies. Also, how much we are getting, how much direct cost the company is making, how much profit directly company is making, right? So in terms of the cost only, so that's cost benefit analysis, right? And then budget impact analysis, that is done usually by the governments, right? Where they check like specific healthcare budgets, if they are taking care of all the new interventions in the new financial years, or they plan for that, right? If something suddenly comes like corona, if suddenly something comes, or if the old policies are going on for the alleviation of what we say that alleviation of anemia from the society, right? Alleviation of TB from the society, alleviation of HIV from the society, like the HIV drops they give to everyone or every child, right? So they cost they they calculate the cost with the budget, and then they make the budget for the upcoming things or the old things, whatever old policies are going on, and that is done by HEOR. These are the methodologies, certain methodologies. And then the next thing is outcome measures tools, right? Where we outcome measures are usually, as I was talking about, the patient reported outcomes. And the first thing is EQ5D, that is European Quality of Life questionnaire with 5 dimensions and 5 longitudes. That is 5D5L. So in that 5 levels. So that is EQ5D5L, and there are certain other things like SF36, Kansas, for cardiology, and there is something New York Heart Association questionnaire for cardiac heart or heart failure heart. So these are the tools which we apply in the patients to check the health related quality of life. We do the surveys, we do the observational studies, we do the registries, and based on that we check the quality of life. And that is one of the major outcome right now, as I was telling you, right? So not only that, but patient related outcomes are mortality, hospitals, hospitalization, readmissions, like in related to like asthma related rehospitalizations. An asthmatic patient, how many times he can get into the hospital again because of the asthma attacks or because of the asthma exacerbation, right? So that can be calculated by the outcome measure tools, and even humanistic outcomes can be done by like checking the caregivers burden, like if a person is taking care of a an old man, right, or a sick man or a sick person, right? So how much they are giving back to the society, or how much they are costing to that, how much they are spending on that, because their jobs goes, their food goes, their stay goes, their, I mean, like there are everything, right, which impacts their daily budgets, which impacts their daily life, right, and which also impacts the mental health. So we check out on everything in the outcome measurements. Not only that, but mental health, caregiver burdens, daily life. So someone's mic is off. Sorry, on. Okay, I hope you will do it. Okay, so outcome measurement tools, right? As you can see here, this is one of the very famous paper, done by I mean, done for the cardiology. Here you can check, right, at different stages. At different stages, like at 1 month, 2 months, 3 months, 4 months, 1 month, 2 months, 3 months. And what they did is they did it for morbidity, they did it for mobility, they did it for self-care, usual activities, and anxiety, depression. They check like at different time points how it has decreased or how it has improved, right? So they have checked, and that kind of result you will get when you do the patient outcome research, or where you patient reported outcomes you check, right? And based on that, you calculate like, okay, if the drug is really effective, if the intervention is really effective or not, right? And then we talk about real world evidences. So real world evidences is nothing but that is like electronic health records, or insurance claims, or patient registries, or wearable devices. And like we get the real world data, and real world data is coming from the electronic health records, patient records, or from the insurance claims, like how much insurance is given for what disease, for what duration of hospitalization. And we do the patient registries, we do the patient surveys, and we take the data from wearable devices, right? So multiple observational studies we do, and we do pragmatic clinical trials, we do retrospective data analysis, right? We take the data like we don't have in India right now, but if you go to US, if you check in US, or if you just search NIH, right? So National Institute of Health. So they have the data of every person, each and every person. And if the researchers wants to do the research, they directly do it from the NIH. Similarly, in the UK, they have NH, right? National Health Program. So they take all the data from NH and do the research, right? So they have their big registries, they have their national registers, for the disease and, outcomes, and they calculate the things from there. And in that, the data is they take all type of data, either diagnosis, that is clinical phenotype, treatments, patient reported outcomes, comorbidities, or digital phenotypes, or surveillance related things, data outcome. Surveillance means the follow-up data of the patient, right? So, and based on that, they create the hypothesis, they create the topics, they do the research, and they do the clinical trials, they do the pragmatic trials, they do the systematic reviews, they do the meta-analysis, and based on that they come to the result, right? So this is one of the another tools or methodologies in HEOR. And definitely the understanding application of that is understanding the treatment effectiveness in diverse populations beyond the clinical trials, beyond the controlled clinical trials. Okay, so because clinical trials are just giving the data in certain population in a very restricted environment, right? But when we go for systematic reviews, or when we go for meta-analysis, or when we go for real world evidences, that gives you the comprehensive data from the from all the sources, all the resources. And now the scoping reviews, not only the systematic reviews, but the scoping reviews, which map the methodologies, which map the entire data, even from the government reports, even from the the state reports or the white papers, or they take from the cases, right? So there are multiple methods where we can use the HEOR and the things, right? And then there are modeling approaches. So modeling approaches also, we have decision analytics models, simulation models, right? So I'll not get into this, but there are certain technical models, like I have shown you here, how they make the models, like for the acute coronary syndrome, like they categorize the events, like if there are the events, like if there is no further event, or non-fatal MI, non-fatal stroke, or death, that is the ultimate like outcome. After that, there is no outcome, right? And then they make the permutations and combinations, and they make the model of that, and they calculate the cost based on that. They make the plateau data, they make the Markov models, and then they look for the complexity of the process, and how much cost is taken for that, how much cost is gone for that, and what exactly and how exactly the outcome has come, right? So they take care of all the factors, they check all the factors, they calculate all the factors which were participating, or which were the major confounding factors or contributing factors to the death, or contributing factors to the ultimate outcome, whether it is improvement in the patient is live or dead, right? So what are the healthcare resources used? So every factor also they take care, and they calculate to make these models, and they find out the best way to calculate the cost and outcomes, right? And then there are advanced methods also, AI, and multi-criteria decision makings, like there are multiple criterias of decision making, there are multiple steps, there are where they check for the cost, utility, ethics, and patient preferences in the policy decision makings. There is healthcare health technology assessment, the HTA, right? So they integrate all the HEOR tools into one framework used by the governments, like in the UK, or HDI in India. I mean, different countries have different models, and then they integrate all the tools, and then based on that they make the perfect method of checking the technology, and the cost and the benefits of the technology, and how much it will be giving back to the society in the future, right? So now let's come to the major part what we wanted to discuss. So Yes. So role of HEOR in public health policies, definitely. HEOR provides the economical, clinical, and humanistic evidences to guide the policymakers. And it helps answers the major questions like which intervention gives the best health outcome for the cost. Like suppose there is treatment A, B, C, right? So we don't know which treatment is best. Everyone claims like, okay, this treatment is best, but which treatment will be best at the best cost and with the better outcomes, with the best outcomes, right? So we have to calculate that, and that will be calculated only by HEOR methodologies, right? So HEOR help us guiding into the best policies. What is best policies? So best, okay, one sec, I'll just check my internet. Am I audible, guys? Just confirm.
So you're
Can someone
audible.
confirm if I'm audible?
Your voice was breaking.
Yeah, because I also got that message. My network is not correct. Okay, fine. Thank you very much, Arman. Okay, so which intervention gives the best outcome? So best policy with the best outcomes at the best cost, right? That we get by the HEOR. Then how can limited resources be allocated for maximum population benefits? Again, that can be calculated when we are calculating the cost of the policies, when we are by these methods of cost minimization, cost effectiveness, cost utility, cost benefit analysis, right? And based on that, we can get these answers, right? What is the impact of a health program on patients' quality of life? So by combining the cost, outcomes, and patient perspective, HEOR influences which drug or devices or programs get funded or reimbursed or prioritized in the public health system, which are most beneficial programs. Okay, so let's talk about the local level impact of HEORs. So there are certain examples. First example, which is the best example I seen in past decades, that is Ayushman Bharat. Right, that is Ayushman Bharat. If you look at Indian scenarios, health insurance and reimbursement policies in the Ayushman Bharat, India's flagship healthcare Prime Minister, Prime Minister Narendra Modi, and he focused on the best part of like everyone now. Recently, they have increased the age also, and they have included all the elderly people. So every family gets the 5 lakh rupees of benefits in the admissions in the hospital costs and all when they get the severe disease or when they get the chronic diseases, right? And the entire family gets the benefits, entire population gets the benefit, entire country gets the benefit out of it, right? So Ayushman Bharat. So how the Ayushman Bharat has come into this? Ayushman Bharat also has come after calculating a lot of multiple levels of calculations, multiple levels of HEOR and their impact into the society, because they wanted to do something for the society, and they cannot launch any program, or they cannot launch any kind of policies to the society without doing the cost benefit ratios, or without checking out how much it will be benefiting the society, right? So one of the best example, if I say, is Ayushman Bharat, right? And another example, if I tell you the generic medicines, right? So right now the cost effectiveness analysis of generic medicines over branded medicines is ensuring the wider coverage at lower cost, because generic medicines are at least 10 times at the 10 times lesser price of the branded drugs, right? So and there are everywhere Jan Aushadhi stores in the entire country. So that is helping, like that is a core area, and that is the core support to the Ayushman Bharat also, and that is the core support to our healthcare part from the government side, right? So these are the policies, just not given directly, but there are a lot of multiple levels of health economic outcome research people, health economists have worked on it. They have checked out whatever the outcomes will be there. They have checked all the resources where to allocate the resources, and the treatment coverage which hospitals will be covered in this program, not only to everyone. See, they are not giving to the adults, they're not giving to the I mean, the criteria to get into this flagship program of Ayushman Bharat, right? So they calculated like which population needs the Ayushman Bharat most, which population needs the such policies most, right, guys? So this is first example. And then if you look at the HPV vaccine I was talking about, right? So vaccination and preventive healthcare program. So cost benefits of vaccines like HPV vaccine into the public health program. After studies shows it was cost effective in reducing the cervical cancer incidences in the long term, right? So that's why they have started the HPV vaccine for our young ladies or our young girls to reduce or alleviate the cervical cancer, right? So vaccination programs got by Government of India. And then infectious disease control programs, IDCPs are very, very famous. As you can see that TB treatment program in India, HIV care program in India. So they started the early initiation of antiretroviral therapies, ARTs, right? So these are one of the flagship programs. These are one of the wonderful programs, started by the government. But definitely these are, the best examples of HEOR also, right? Because HEOR cost benefit analysis, tells the government like how much to include, what to include, where to include, which population to include, right? And what cost we can give, how much cost we can give, how much resources can be allocated, how much budget can be allocated, right? So that all can be done at the local. I mean, at local means we are talking about India, right? You can see Saaf Niyat Sahi Vikas, right? So they are like eliminating tuberculosis ahead of the global target. And they have done the treatment for they have established, they have given the TB kits or drug sensitive treatments for the almost 4 lakh people, right? And not 4 lakh people, 4 lakh dot centers they have created in India. I'm so sorry, 4 lakh dot centers, and 5.5 crore population they have covered under these 4 lakh dot centers. And not only that, along with that, they give 500 monthly nutritional support also to the people who are having the TB and under the dot center, so they can get the best diet also for them. Okay, so that's why these things are very much needed. And they create such programs like not only the drugs, not only the ART therapy, not only the dots, but along with that, they get the nutritional support also. Okay. Feedback from that could be that is not from the our side, that is from the KIHT side. They will tell you. Okay, and I think now lecture is going on, so better focus on the lecture, right? And then the fourth very important example, if I tell you, the hospital and state level decision making. Hospital and state level decision making, like hospitals uses HEOR for formulary decisions like which drug to keep for the best benefits, right? Which drug we should not include in the hospital, which drugs to be written to the patient, which drugs not to be written to the patient. Though that's a different thing. Like now the hospitals look at the benefit cost benefit more than the patient outcomes. But yes, right, but yes, again they think that thinking also comes by the HEOR. That decision comes after the HEOR calculations only. That decision comes after the HEOR tools and methodologies only, right? Whatever decisions like which drug to keep in the hospital, which devices to give. Like there are like the multi-specialty hospitals where cardiology is practiced, where they have the cath labs, where they have the where they put the stents, right? So they calculate they calculate the cost of like which stunt will give the most what we say the cuts, if I say in the like commissions. Like the majority of the corporate hospitals, they look at like which stunt or which device is giving more benefits in terms of cost to the hospital, right? And then the community health priorities, definitely in everywhere, not only in India, you will see that there are the rural public health centers, rural hospitals. They conduct the screening programs for hypertension and diabetes, so they can tackle the public health problems. They can tackle the public health epidemics or like non-infectious diseases before they arrive, right? They can guide the patients, they can guide the public, and they can take care of the nutritional programs. They can take care of the screening programs programs, they can take care of the medicines, they can avail the the best medicines and the best therapies within in time to those areas or centers, right? So to do that, they do the interventions as well. And like for the hospitals and state that there is one wonderful example of biosimilar insulin, right? So some government hospitals prefer the biosimilar insulin over costly branded analogs from after HEOR showed the equivalent outcome. So see how wonderful example is this. Because see, if you get the the other insulin medical stores, they what they do is they give the costly insulins. But when you are using the biosimilar insulin, definitely everyone gets that idea, like, okay, if this vaccine is costly, if this insulin is costly, that will be more beneficial, that will have the more good outcomes. But based on the HEOR, when they found like biosimilar insulin is also having the similar equivalent outcomes or the good outcomes, so they started giving the biosimilar insulin, which is far lesser costly than the normal insulins, right? Biosimilar insulin is almost, I'm telling you, I'm almost 15 to 20 times lesser than lesser costlier than the normal insulins, the monologue, or the other analogs of the insulins. Okay, now let's look at some global examples, right? The WHO model list of essential medicines. So at the global stage, HEOR provides the evidences, backbone for the international organizations, donor agencies, and the high-income country regulators. It saves the drug access to everyone, reimbursement frameworks, global guidelines, and funding priorities, right? So that can influence the millions of the lives worldwide. So first example what I take here is WHO guidelines for the essential medicine list, right? So HEOR evidence is the is the key when deciding which medicines should be added to the essentials list. Like example, inclusion of direct acting antivirals, DAs, for the hepatitis C was based on the cost effectiveness data showing the long-term savings by preventing liver cirrhosis and cancer by giving direct acting antivirals, right? So these are costly drugs. Those direct acting antivirals are very costly, but still they have included in the WHO's essential medicine list because these drugs shows the long-term savings or long-term prevention of liver cirrhosis and cancer. Okay, and that ensures that other countries also can adapt the evidence-based affordable international interventions globally based on the WHO guidelines, right? So that's how we decide, that's how we even follow sometimes we follow the WHO, right? Because they do the studies worldwide, they come up with the evidences, and based on that evidences they do the analysis, and based on the results we come to the conclusion of like what type of things can be included. Then if you look at the second thing, COVID-19 pandemic response, right? So HEOR analyzed the vaccine procurement and prioritization policies. Like if I give you an example, countries like UK and US, they use the budget impact analysis like to decide which vaccine to buy in bulk, which vaccine to give it to the society or the people, right? Like in India, we chose two vaccines, right? One was from Bharat Biotech, one was from Pfizer and Serum Institute of India, right? One was Covaxin, one was another medicines, right? And another vaccine which was made by Serum Institute of India and Pfizer. So because they chose the the best vaccine at the lower cost, and because that has to be given by the government of India, which has to be given by the the governments, which has to be given by the federal government, so it can come up with the best effectiveness. It can come up with the best alleviation of the problem it was given, right? So and even the even both the vaccines were very successful, right? So they chose vaccines to give it to the population in India, right? The US has chosen these vaccines to give it, right? नैना शर्मा,
मीटिंग की क्वाइल तभी आएंगी जब आप मुझे एग्जैक्ट रिक्वायरमेंट दो, मैं डबल करके बुलाता हूँ क्योंकि
someone's mic is on. Okay, then third is HIV and AIDS treatment scale up. That PEPFAR program. PEPFAR programs, I don't know if you have heard of or not, but PEPFAR program is for the multiple years. It is for the decades. It is almost for the 2 decades. Okay, and in that US, US and UK usually they fund the programs, they fund the ARTs, they fund the policies worldwide, right? They fund through the WHO, and you can see this diagram like. How they have increased from the PEPFAR program, right? In 2004, 2000, 2004, it has started 2004, they have started, and then how the number of people who got the antiretroviral therapies, ARTs, has increased. And now it is more than 20 million of the people, 20.5 million people received. In 2023, 20.5 million people received ART through the program, through the PEPFAR program worldwide, especially they got in the African regions, because African regions are not very rich and they cannot afford such programs. So globally, the global societies, global countries like US, UK, and the WHOs, they take up such programs, and they do all the studies to get such programs to certain countries which cannot afford the healthcare programs like this, and which can help. So PEPFAR program is for the HIV and AIDS, and they give the ARTs, they give the free antiretroviral therapies for the people worldwide, and they supplies to the different countries like like the underdeveloped countries, or the countries which are in the early phases of development, right? So PEPFAR program is also, so look at this, like how they come up with the resource allocation, how they come up with the, like, which countries needing the needed the most of such things. Like they check out by the HEOR only. They calculate the things, like they calculate their budgets, they calculate their budgets of the country, they calculate the population, they calculate the number of the kits they need, they calculate the cost of the vaccine, and they calculate the cost of ARTs, and then they give that, right? So it is a huge process of HEOR. HEOR is included in such programs. Okay. So then high income countries reimbursement models, like in US, Canada, or Canada or USA. Usually in Canada or Australia, everything which is related to the population health is taken care by the government. Government gives the insurances. Government is reimburse to all the health related problems in these countries. So high income countries reimbursement models, global financing, like the World Bank gives the money for the health, right? And Gates Foundation, Gavi, they give the they fund the populations, they fund the countries for countries to you know to the fight to the diseases, fight to the social discrepancy or evidence support financing for rotavirus and immunal vaccines in low middle income countries. UHC, I was telling in the first or second slide, universal health coverage. So HER supports the global efforts towards the sustainable healthcare systems by identifying the interventions that provides the most health per dollar spent, right? How much they are getting, how much they are improving the health of the society per dollar spent. Okay, studies comparing like hypertension screening, late stage cardiac interventions by WHO and World Bank policy toolkits. Okay, so future of HEOR, I'll not take much time in that. Future of is nothing but digital health and big data integration, like the electronic health records, wearables, mobile health, precise economical evaluations. Monitoring has been launched, and that helps the society, that helps the patient a lot in maintaining the glucose levels. It is maintaining the their insulin levels, and getting the better outcomes and better treatments by the industry, or sorry, by the hospitals, right? So digital health and big data integration, and then personalized medicine, patient-centered outcomes, right? Like the I mean, the quality of life now, as I was telling you, now they are not focusing on the length of the increased length of the years in life, but they are looking at the patient-related, health-related quality of life, how much the patient is happily living. Either they are living 2 years, 3 years, but they are living happily without pain, without sufferings, right? And then personalized medicine, now they're focusing on the gene therapies, biologics, or precision oncology or precision medicines, like for example, CAR T therapy, evaluating considering the life survival gains or upfront costs. Like, so there are multiple things which are right now booming in the you you have to divert your focus from the traditional part, evaluate healthcare models, like improving the outcomes. Models are improving the outcomes at the agreements between the pharma, insurers, and the governments. They are making multiple agreements now. They are working in the collaborative environment. Previously, they were not the collaborating environment, but now governments are tying up with the insurers. Now governments are tying up with the pharma companies for completing their policies. They are funding them. They are giving them the subsidies to provide the best health to the people, right? And again, the expanding role in low and middle income countries, right? Like Africa, Southeast Asia, India, and these countries are getting the benefits under the universal health coverage program, which is funded by US or UK sometimes, most of the times, right? And then global collaborations and emerging methods like machine learnings, multi-criteria decision makings. So the global collaborations and policy impact, like including the health into the sustainable development goals, right? So such things are really giving the benefits, and such things are really need of the hour in the HEOR, where we just don't need the data from one country or one state or one place, but we need the data, and we need the collaborative data and collaborative analysis and collaborative outcome analysis from the different countries. So we can plan, we can help the low middle income countries, we can help the underdeveloping countries, and we can help them sustaining with the health, with their population's health, or reducing the health related problems in such countries or in such populations, right? So we need that collaborations and policy impact worldwide, and that is the future of it. Now there is some last three slides, call to action. So for students and for academicians and researchers, so for the students, like, guys, please build your expertise in HEOR, pharmacoeconomics, and real world evidence. Please learn this. This is a wonderful area, and this will gives you not only the good job, but you can contribute to the society, you can contribute to the our country, you can contribute to the world by learning HEOR, pharmacoeconomics, and real world evidence, because this is the need of our. Engage in internships, engage in online courses, research projects to strengthen your profile. Become the future ready professionals who can contribute to the healthcare decision making, right? So this is a call to action. Just not drop HEOR, pharmacoeconomics inside, right? And then for the academicians and researchers, definitely include the HEOR modules into the pharmacy, medicine, and public health curriculums, and start the ISPOR chapters. Start the HEOR modules into the pharmacy colleges. Collaborate across the disciplines, like for the economics, for the epidemiology, for the clinical sciences, to generate the impactful research. Publish and share the local HEOR evidences, like whatever you are doing, observational studies, registry studies, or surveys. Publish them, and help the society getting the real time evidences. Okay, so that is for academicians and researchers. And there's something for policymakers and for the global collaborations. So definitely for policymakers and healthcare leaders, use HEOR insights to design the value-based reimbursement models, affordable health insurance packages, and invest in real-world data infrastructure like registries. The government registries, like US have NIH, UK have NH, but we should also need something in India. Digital health records to strengthen the evidence generation. Promote the equitable healthcare access by ensuring the policies, balancing the costs, effectiveness, and fairness in the policy distribution to the society. Like some people get all the benefits, some people don't get a single benefit, right? So the fairness in distributing of the society, I mean distributing of the policies to the society, is very important, right? So that is for policymakers. For global collaborations, definitely industry, academia, and government should come up, and they should come to the partnership to teach HEOR, to work on HEOR, to research on HEOR, right? So definitely align HEOR efforts with sustainable development goals. And you can see this was the 12th International Health Dialogue, done by Apollo, and in 2025 recently. And our Foreign Minister Dr. Jaishankar also has attended, and the ministers and the people from different countries also have attended this in Apollo. That IPSC was conducted by Apollo 12th International Health Dialogue, right, where they talked about HEOR and the policy making. So I invite all of you to our upcoming international online program, which is Applied HEOR and evidence-based synthesis internship. That is 8 weeks real-time practice, practical learning, starting on 24th September, in the collaboration with Dual Sphere Consulting, run by Dr. Richa Goyal. Okay, guys. So if you're interested, you can just join this program. This is a 8 weeks program, 8 weeks internship in HEOR. Okay, and your feedback, if you want to give the feedback, I think the KIST is taking the feedback. Please give your feedback. That will take us, and you can connect with me. Now it is the time for the question and answer session. So thank you very much again, to Dr. Kavita, to the KIST management team, and Dr. Kavya for the coordination. Thank you very much for inviting me and giving me this opportunity. Now over to you guys for the question and answer session. And you can connect me anytime if you need any kind of support.
Thank you so much, sir, for that insightful session. If anyone has any questions, they can unmute and ask, or you can either put it in the chat box. Regarding the feedback form, we'll put the Google form link in the chat box shortly. Anyone with any queries?
Yes, guys, anyone with any queries, you can take the, I think I asked for the feedback form also. Yeah, we can share the feedback form.
We'll share. We're just sharing. Any questions? We have 90 participants.
Yes, guys, any questions do you have?
We also have with us the leader of ISPOR India Karnataka chapter, Dr. Anand Nagappa, sir. We would love to hear.
Hello, sir. Namaste. If he's here, then he's my guru. He's my mentor. Yes.
Is he here? So,
I'm not sure. Okay, so there is one question from Parth Jogmage. Sir, as I'm the second year PharmD student, what can I do to study about HEOR? Right now, focus on the therapeutics in the second year, third year, and when you are in the fourth year or fifth year of the PharmD, then definitely look into the HEOR. In fifth year, do your study, do your project. Okay, fifth year project, 6 months project, do in the HEOR. HEOR is not just like cost effectiveness, but it is about calculating the disease burden. Okay, do something on the disease burden of any disease like heart failure or infectious diseases, or any kind of take up some project on disease burden, take up some project on healthcare resource utilization. Okay, health resource utilization, HRU. Okay, drug utilization review, DUR. These all are the part of HEOR. Okay, these all are the part of HEOR. So from the fifth year, start learning HEOR. I mean, from the fourth year, do some course, 6 month course or internships in HEOR, and learn HEOR and do your project in the fifth year in HEOR. And then a 6 year again, if you get time, do one long-term project or survey in HEOR, cost benefit analysis and all, something like whatever knowledge you achieve, you can go for it, and that will help you in achieving your goals in HEOR studies. And then it will help you in getting the and write one systematic review, or some scoping review based on the cost benefit analysis, or based on some healthcare resource burdens or something like. So do some research, do some practical research. And from the fourth year you can start learning 3 months or 6 months courses in HEOR, or outcome research. Learn how to do the RWE, real world evidences, how to do the systematic reviews, how to do the meta analysis. That will help you. Okay, I think B should also got the answer that to answer to them. Search and HEOR. Any other questions, guys? I just showed Nikhil, you can join our internship. You can just connect with me, and we are running the internship that is starting on 24th September. You can join us for the internship, right? And yeah, and there are multiple other things. I'll suggest you when you are contacting.
Those who also want to learn, like you have no idea about what is health technology assessment, what is health economics and
Absolutely.
outcomes research. So every year in March we have a workshop. So it's the International Fellowship on Health Technology Assessment from 10th to 15th. It's conducted by Kalam Institute of Health Technology, and we have faculty coming, as ma'am said in the beginning. We have faculty coming from University of Washington, University of Toronto, University of Arizona. So if you would want to be a part of it, kindly get in touch with us. And even we have many people who have interned with us, since KIHT is a regional resource center under DHR who carries out health technology assessments. Yeah.
Okay, guys, if no questions, thank you very much. Any other questions, guys? Okay, Abhishek Datta has one question. How does HEOR differs in India compared to developed countries in terms of data, healthcare system, and payer decision making? Are you seeing it improve in near future? Definitely. See, first of all, you have to understand two things. First thing you have to understand, India is one of the largest population. Okay, so calculating HEOR part or calculating or distributing the policies and distributing the policies to the correct population is very, very tough. Okay, and then affording the cost. Okay, affording the cost for the entire population or the even number of the population, because see, we have 28 states, and we have right now 10 union territories with us, right? So we have almost 38 states, right? And 38 states with the population of 1.5 billion, right? And in that, definitely, HEOR things or the healthcare budget distribution, healthcare policy distribution, making such policies are very, very difficult. And second thing is, being the being one of the largest population being one of the largest population, we are the low middle income country. We are not developed country right now. We are developing country, right? So we have very least budgets. We don't have the very high budgets for healthcare. We don't have the high budgets for everything, if we say, right? Because we are low middle income countries right now. Very proudly, why the second part of your question is, are you seeing it improve in the near future? Definitely we can see right now under the leadership of our prime minister, his policies, how he is making the policies, how he has launched the Ayushman Bharat, how he has launched the Jan Aushadhi, right? So these are something which give us a very good hope in the future for the healthcare, and which gives us a very good hopes for the good health of India, right? Because they are taking care of multiple things, and they are our recent government is looking for the wonderful health of the India, and that's how they are coming up with wonderful policies. They have recently started the medtech startups, like they have started medtech Mitra under the ICMR. They have they have done wonderful job in the corona time, and right now we are the fourth largest economy in the world. So definitely we are improving, but and definitely we are considering a biggest population and low middle income country tag. Still we are getting very, very fast into that zone where we will be having our best health, best payer decisions, and best healthcare systems in India. And right now, again, if you look at the the comparison with the world, we are the hub of the medical tourism. You might not be knowing, but we are the hub of medical tourism. People come from almost 100 countries to take the best healthcare benefits or utilize our hospitals, big hospitals, and services, healthcare services in India, right? So definitely it is improving, and I'm seeing that improvement. I'm seeing that improvement because you can see it is very much visible. You can see the Ayushman Bharat, you can see the Jan Aushadhi, you can see the other policies, you can see the our how our economy is growing, right? So a lot of things are happening. Definitely it is help it is happening. What's the most common mistake you see organizations make when designing the HEOR studies? Mm, okay, so see, when we look at the organizations, definitely the things come as the population and uncertain diseases, uncertain like, see, if I give you an example of like, suppose Maharashtra. See, Maharashtra is one of the very big state in India. I mean, though in comparison to other states, and it's very large population, and uh, there half of the population, not only half, the 70% of the population of Maharashtra is living in the villages or in the rural areas. But again, not only that, but in the rural areas also, almost 25% or the 35%, 30% of the area comes every year under the drought, right? And because of that, the malnutrition and the problem related to the hormones, problem related to the what we say, that micro elements in the body, and problems related to the dehydration comes every year, right? So when these governments or the organizations or the things, they look at a big picture of Maharashtra, they always get confused of the natural calamities. They get confused of the things which can uncertainly comes into the picture, right? And again, the large population. But if you come to the private organizations, like the companies, if we, because you have not specified what you are asking. So if we talk about the industry people, they usually hire the best team of HEOR. They take care of the all the aspects of the HEOR. But again, where they fail is competition. Okay, where they fail is competition. Okay, and where they fail is the government partnerships, right? Because the government partnerships and the and calculating those things is very, very important and very, very tough also. Okay, so that is the problem what usually companies face. But the industries usually hire the best HEOR teams, best people to calculate the cost of the drugs. But again, the competition is major factor. Okay, they cannot calculate that, they cannot come to that, because in India, in this competitive era, there are, in the pharmaceutical companies or in the med tech or in the variables, again, if someone starts, then the copy happens immediately. The someone starts something new, immediately within 1 year, within 2 years, the copy comes, right? Within 2 years, 3 years, and the timelines of patent also is very less in India, right? So these things affect those things, affect the costs, right? India is, though I always believe India is very rich of resources. India is very rich of the raw material of making the medicines, making the devices, or making the drugs, though we have very low cost. But again, being a large population and being the very big competition in India, definitely somewhere they lose that part, right? Otherwise, India is the hub of medicine, hub of pharmacy, and a lot of things are there, right? So I hope it answered your question. Okay, somebody's there. Deepthi wants to ask some question. Yes, please unmute yourself or write. She raised the hand.
Deepthi, do you have a question? Because you had raised your hand. And if you have, you can just unmute and ask. Meanwhile, we see Dr. Nagappa has joined us. So if you could.
Hi, sir.
I think.
Sir, are you able to unmute and speak for some time?
Hello.
Hi, sir. Good evening.
Good evening. I did give a very elaborate presentation with the HEORs.
Thank you,
It was
sir.
very well. So they are very clear. But also, you must until take your this because the activity also the test your. Okay? So, thank you very much. If any topic you want me to speak, I will speak. Okay.
Thank you, sir, but your voice is breaking actually in between.
I'm traveling actually. No problem.
Okay, sir. Thank you very much, sir. No worries, Ariman. I think we can wind up.
Yeah. Thank you, everyone. Can we just, if everyone could just turn their camera on so that we can take a group picture and then we can wind
Yes,
up
that
the
would be
session.
great.
Yes. I request everyone to turn their cameras on if you are still awake. Yeah, we can see you, Nagappa sir. Thank you for joining us.
Thank you, sir.
Done? Okay. Thank you, everyone, for joining this session. Thank you, sir, for the insightful talk.
Thank you, everyone. Thank you very much.
Thank you
Take
so
care,
much.
guys.
With this, we close our session.